Thank you very
Lisa.
much, Jen. I
Yeah.
appreciate it. And I am very honored to be here today to talk to you about this fantastic, really a very wonderful topic. We find this very, very helpful in our little neck of the woods. And working at Elevated Health has been an honor for me, and I really enjoy working with Region 8. One of the things that I'd like to do is start with a story and level set the conversation for us. So, what I'd like to do is talk a little bit about how integrated health and working with community organizations can be a very, very powerful um, part of any of your organizations. So, what I'm going to do is start with when I started with Elevated Community Health, I was 2 months into the job as the director of behavioral health. And I had worked in integrated behavioral health before, but this company works with dental, primary care, as well as um, primary care and behavioral health. And we were just going through an electronic health record change. And we were on day 2 of our electronic health record transition. So you can imagine we were deep into, oh my God, um, how is this going? Nobody knew their left hand from their right hand. And it was scary. Patients and the clinicians were, where is this form? Where is this form? I'm not sure what to do with this. And it was really, um, one of those words where you just kind of throw everything up in the air and you weren't really sure what to do. So it was pretty messy, let's put it that way. And my dental director came to me and said, I have a woman in the our dental office and she can't stop crying. And I looked around and all my clinicians were busy with patient care. And I said, okay. Um, I said, have you done the PHQ-9 and the GAD? And they said, yes, she's filling that right now. However, the PHQ-9 said that she was positive for suicidality. And so for those of you, I can't see who's a clinician in the room, but I'm assuming that there's a few here. A PHQ-9 is a depression assessment and the GAD is an anxiety assessment. And so immediately I wanted to make sure that we interacted with this patient that day. So I sprung over to the dental office located right next door, and I asked this woman to kind of come back and talk to me a little bit about maybe what was going on that day. And working in an integrated care setting, you get to figure out a little bit about what's going on with them and how you can help them in that moment. And so we did a warm handoff, and I sat down with her, and she told me what was going on with her. And she had said that that morning her son had said something to her that her husband had been saying to her for years, that she thought was verbally abusive. And it was extremely verbally abusive. And when her son, who was age 6, said it to her, that was her way of knowing that something had changed. And it was really hard for her to see now that her husband, who was treating her horribly, had now transferred over to her son. And so she made that decision that today was the day that she was going to leave him. And so she, after her husband left for work, she packed up all of the things in her house and everything that she could for her kid, including a stuffy that day, and packed up everything into the car that she could, went to the dental office, was going to have a procedure that day and pick up her son and leave with whatever she had on hand. It was very powerful, but it was also extremely scary for her because she didn't have much money on hand. She thought she could like travel to her mom's across the country, but she really didn't have many resources and she couldn't stop crying. Um, she had tried many times to reach out to CPS, and without a lot of luck, didn't really know what to do. And she knew that if she took him across state, that there would likely be repercussions because he had done the same thing and took their child here to Colorado. And so she was lost. And we had a lengthy conversation about what that would look like and what were her choices. And so in that solemn space of being a clinician with a patient who had difficult choices, I had a very difficult responsibility of who are the right resources in my community and neck of the woods that I can trust with this patient in this type of dire situation. And I was only 2 months into the job. And I have to be honest, I just knew the name of the resource, but I hadn't made connections with this resource yet. I was a little scared, not gonna lie. And so I asked for her permission to contact them and see if we could make arrangements for her. And she gave me her permission to do that. And I picked up the phone and I had to leave a message. I was like, oh no, this is not really what I wanted to do. And I asked if they could please call me back as soon as possible. And I asked for her patience if it would be okay to wait. And we waited less than 10 minutes and they called me back. And I was thanking my lucky stars that they called me back, and we had made arrangements for her to stay in a shelter that night with her child for legal representation if there were repercussions, and for her to relocate the next day across the country to a safe place. And I don't know that I've ever seen somebody be as thankful in that situation as I've ever, out of almost 15 years of practice, in that moment. And she never stopped crying the whole time I was with her, but that felt amazing to be able to help somebody in that situation. And this makes a huge difference as to why we create these types of relationships. So at the end of the day, the people we serve truly get that care that's necessary in the moment, right then and there. So with that, I want to talk about how we create and why we create these relationships today. So elevated community health is just a little tiny, we serve a pretty small area. We actually serve just Summit, Lake, and Park counties. And then last year, we served all of 56,000, or actually, excuse me, the total population of these 3 counties is only 56,377 people. And in Colorado, believe it or not, this is only 1% of 1% of the population for Colorado. So tiny, tiny percentage. And when you look at the Colorado Intimate Partner Violence statistics, they say that 1 in 2, now nationally, 1 in 2 and 2 in 5 men are victims of intimate partner violence. However, when you look at the Colorado Intimate Partner Violence statistics, 37% of women and 31% of men have experienced physical, sexual violence, or stalking by an intimate partner. What I found very enlightening was when I looked up our statistics. They don't classify it as intimate partner violence, but when you look up our statistics in Summit, Lake, and Park County, we had only 95 reported cases of domestic violence. I'm going to ask a few questions to you guys as to why you think that might be. And I'd love to see some answers in the chat, because this is less than 1/4%, which is really frightening. And that's nowhere close to the statistics, either in Colorado or nationally. And that's way off because we're in a pretty underserved population. And I'm fascinated by that. Does anybody have any ideas on that?
Yeah, I'll read them out for the recording. So small population, so concerns about people knowing each other or lack of confidentiality. That's one idea. Another says, does reported mean reported to a clinician at Elevated Health or to law enforcement?
Law enforcement.
Law enforcement. Feel free to keep adding comments to the chat if you like.
Absolutely. I'm going to give a couple more seconds and see what other answers roll in.
So we got one that says resort communities, so less long-term population, perhaps they don't have the connections they need to go where help is needed. Or they don't have connections to know where to go if help is needed. Another person wrote, fearful that nothing will be done about it.
Great. Very good. I also looked a little bit further into the way that things are classified by the police. And one of the things that I thought was really interesting is they look for something they can charge. So this is kind of interesting. And I don't know this for sure, but we happen to know some of the chiefs around here. And so the way that they classify this in the statistics is, what is the primary charge? So they don't look at this as a global thing. They look at what is, is it stalking? Is it simple assault? And so they look at this very differently. And so part of this is more education to our systems folks and how they look at this, and that kind of change. And law enforcement, but they also have to do what legally they can do. And maybe our systems don't necessarily connect the dots there, but I found that pretty interesting too. So just food for thought there. So Elevated Community Health is a federally qualified health center. So that means that we are a safety net clinic and we serve all regardless of ability to pay. We are an integrated clinic and we have 2 main clinics, one in Leadville, one in Frisco, and 13 school-based clinics. So everybody from kindergarten all the way up through high school, and we're throughout all those 3 counties. In 2024, we had 37,157 unique visits, and our uninsured population was 49%. So we have a pretty big population that doesn't have the ability to pay for their health care. And we do sliding fee scales and things of that nature to make sure they have access to their health care services. One of the things that we make sure that we want to do is that we are screening for intimate partner violence. Human trafficking is something that we are working into our policies and procedures, but that is coming to. So I have where I am and where I want to be, just so you kind of know where my scale is and kind of where I am on my journey as the director of behavioral health. Sorry, my ear is losing weight again. So we have multiple pathways for screening. We do this based on the visit type currently. So on all of our new patients, our annual women's wellness, prenatal, OB, and What's that other one that's hiding back there? Sorry, oops. Let me go back one there. Sorry, I moved that a little too fast. In our OB visits. We use the HITS evaluation, but we do it as a one item screening question. And it's essentially the question of how often does your partner physically hurt, insult, threaten, or scream at you? And then there is, I think it's 5 or 6 answers as to a range of knowing how that goes. So never happens up to, daily kind of situation. And that allows for our clinicians, whether it's dental or whether it's primary care, to initiate a warm handoff. And I'll talk a little bit about what that looks like um, to our behavioral health consultants who are stationed within the primary care setting. We also use a prepare tool, which is our social determinants of health school screener. And that was done by Kaiser, I believe. And that assesses for really everything from, how is housing? Are you struggling with paying for co-pays? What does it look like for transportation? And this really is an additional screening for us to make sure that we're looking at the whole person and any of their needs. We do this on all patients, new patients, and annually in our clinic as well. Another area that can be very, very helpful is uh, using EHR flags. And not all systems are set up to do this, but if you have an electric health record, it may be helpful for you to delineate any confidentiality issues, like you may be suspecting potential intimate partner violence or potential trafficking that maybe only the clinical team may see. So that may be another way for you to identify a flag if there's something that you may have a concern over. We also use something that's called health gaps. So this may be something where there's a screener that hasn't been done, and we identify that those screeners need to be done and put those in our notes for that person to be done that day. And sometimes those screeners give us a lot of information that just got missed. And so we want to make sure that we're utilizing things of that nature. Another area that also is very, very helpful is to use our school-based health centers. We do what's called Title 10 visits. Again, we can use these from more of a confidential standpoint. So you can have confidential behavioral health visits. Title 10 by that nature is you can have your sexually transmitted tests done, emergency contraceptives, birth control, things like that. Or if parents just don't want their kids to engage in behavioral health and they are a self-consenting adult, we have ways to kind of lock that information down so we can honor a youth who wants to self-consent to behavioral health and things of that nature. So I'm going to go ahead and pause here and answer any questions that people might have so far.
Yeah, that's perfect timing because we did get a question. Are you using Prepare 2.0 or the original Prepare Screener?
I believe it's 2.0.
Can you share a little bit about why you guys did decide to move on to the Prepare 2.0 over the Prepare?
I honestly can't because we had a couple different options, and it was more of an electronic health record that was the option that was given to us. So I don't know that we had an option for the Prepare versus the Prepare 2.0, but I believe it's the Prepare 2.0. And I'm sorry that I don't have the full option, but I think it was a 2.0. It's a long version of the Prepare. But I'm happy to find that out for sure. and send it in any follow-up. Any other questions?
Oh yeah, the or question asker says that's okay. They were just curious. So.
Okay, sure.
And we don't have any additional questions at this point in time.
Sounds good. One of our standard operating procedures for intimate partner violence is really the guiding principle of treating every patient as if they were part of your family. If I think of, I always use my mom. If I saw my mom in the clinic and I knew that she was kind of beaten down, not physically, but emotionally, well, anyway, if I was sitting across from my mom, how would I treat my mom in this situation? You think of it from that lens, and that's kind of how I treated the woman in front of me that day, is how would I handle this situation? What kind of situation would I want to have her walk away from that day? And I would want to do anything that I could to make sure that she felt comfortable no matter what. Obviously, from a trauma informed care, make sure it's, you know, they felt safe, compassionate care, and that it was integrated. Making sure the dental knew what I was doing, that I talked to the primary care doctor after that visit, which I did, and let them know, hey, this is what happened, and this is how I handled this. And that they would most likely not be showing back up into our system and they would be leaving the state. Things like that. So we all are talking as a group. Screening tools that you can use. These are amazing tools, and you may have heard of these before. Something called the cues, HITS, which I referenced before, HARP, another assessment. And I found a ton of great information on this. It's called Futures Without Violence. When I was looking for things, how to grow our team, this is something that I really liked a lot and will continue to go back and reference how to train our team. I also, this is an area that staff really struggle with. It's almost like they don't want to use the language or are scared to use the language. They're really okay with like identifying physical signs, hands on neck, things like that, or if there's bruises on people. The physical stuff is easy for them, providers. But I'd almost encourage all of you to look outside of the box, think outside of the box. When you see somebody that comes in for a lot of somatic complaints, um, again and again and again, think to yourself, okay, what am I missing? I'm not seeing something. Or, it could be a lot of stomach complaints. Think about anxiety and where it's rooted, and maybe ask a couple different questions. Make sure that they're getting that one question or that, one of these screening tools. We've had kind of some interesting run-ins with partners, kind of wanting to be in the visit and wanting to answer questions for their partners. Pay attention to things like that. Make sure that there's a level of separation between a partner and the person that you're treating. So somebody feels comfortable answering those questions. If you start to see a lot of missed appointments, and then somebody shows up wanting their medication, and it's very important for that person to get medication, and all of a sudden there's this level of urgency from that partner, or some unintended pregnancies, and all of a sudden there's a lot of lethality involved. I encourage you to start to think a little bit outside the box and start to get on your curiosity cap, just so we make sure that we're asking those questions. A couple of things that are also super important too are really those confidentiality pieces. You guys familiar with the 21st Century Cures Act? I'm hoping I see some hands up or heads nodding. There's some really helpful things around compliance for this and ways that we can benefit our patients. If a patient is not, if there's a way that's essentially you would put a patient at risk by releasing their records to somebody else, there's a way that you can essentially not release that record. And so I would encourage you to make sure and work with your compliance departments or your quality departments to make sure that you can, or there's policies around that in your companies, that you can honor your patients and that are experiencing IPV or trafficking. So someone else can't request their medical records and see maybe information that you don't want to do that. And also think about the way that you're documenting and being very broad with your documentation and not utilizing as specific things in your documentation. And again, going back to your EHR flags and safety planning, what are some things that they can do? And who can they call? Things of that nature. Again, I'm going to go ahead and stop and ask for any questions that may have surfaced for that.
Absolutely. We don't currently have any questions, but folks, please put any questions that you have for Lisa in the chat box and we'll get them answered.
Sounds good. So warm handoffs. How do we handle this in the clinic? What we do is we have a very fully integrated team, and we actually, our behavioral health consultants sit in the hallway with the kind of pods of the primary care center, and our providers would come to us if anybody would screen positive for IPV, and they would let us know, hey, I've got somebody who, I'll just say Sally Joe, who is screened positive for this, and they also have screened positive for depression. Can you please see them in room 3? That's probably all the information we would get. And then we would go into that room and we have all of our disclosures and everything already signed when they first come in the clinic already. So we would review those screening results with them, talk to them a little bit about, in their own words, what's going on with them. We want to make it non-threatening, you know, what's going well for them, you know, in their world, what's
Hi,
going,
Melissa.
you know.
My name is Pamela Euler. I'm a social worker. I'm calling.
Oops, sorry about that. Got a little interference. What's going well for them, what they're struggling with, and what's maybe one thing they would like to move towards changing. So kind of really a solution focused approach for them, so we can kind of move in the direction of one thing that they can work towards. And so that's kind of how we frame our maybe 15-20 minutes with them that day. And then we would also let them know that we work more of as a consultant with their doctor and that we chart in their the medical chart, and that we're actually going ahead and working with our primary care provider. And if there's any areas of safety, we would handle it, you know, as any other provider would, but that we would also follow up with their doctor too. So what we would want to do is if they bring up the area of the intimate partner violence, we would want to talk a little bit about that. If they wouldn't bring up the intimate partner violence, we would talk a little bit about, you know, the provider asked us to come in and talk a little bit about this area and see what your area of concern is related to that. So they may not bring that up for themselves, but we would still want to address that and see if what their level of motivation is to make changes around that, because not everybody is going to be at that willing to make a change. We know that it takes sometimes a long time to make changes in that world. And sometimes it's about just starting the thought process and getting the right resources and just planting a seed and getting them to work towards that goal of what they want to make their next change towards. So we want to just get them in the mindset of moving towards that if that's what they want to do. So that's kind of what our role is as a behavioral health consultant for that. For us, it's a big help for us for communication and warm handoffs. We want to make sure that we're communicating really across the board. I would say that dental is really amazing at identifying signs of trauma. I don't know why this is. For those of you who have dental, maybe it's that people get really nervous with dental, but dental, when you're in a dental chair, you tend to talk a little bit really nervously. And I think people just are naturally nervous around dentistry. And so that tends to show up for a lot. Plus, I think that this is just my own personal opinion. However, I believe that most of the things show up in the mouth first. I think there's a lot of studies out there. So cancer tends to show up in the mouth first. Diabetes, signs of things of like that. So we're really good at helping. The dental tends to show up, tends to be a really good feeder for our primary care. So they usually are really good with that, saying, hey, we're noticing signs of something going on. But I always think to myself, teeth are really interesting because if there's physical signs of trauma, that is something that happens. And they can really kind of talk about that. Medical is great at documenting injury and initiating safety planning. And behavioral health, we're great at doing, obviously, counseling and providing crisis support. So the main issue I think that is really, really helpful is what do we do when we have somebody and we can provide only so much support? We need others around us that have a network to be able to provide additional support to this patient in front of us that needs help. So again, let's think outside the box. What kinds of support do we need? And who are those partners in our surrounding area, tight little area, and bigger networks? So I always think to myself, let's start with the patient needs and the accessibility of the area. One of the things that I'm really big on is I talk about collaboration over competition. Really, it's important. I think that sometimes we're always fighting over, well, we all do the same thing. So why can't we just work together? We're serving the same patients. Let's find a way to work with these patients together. And by doing that, if you understand the collaborative partners book of business, you can easily complement each other. For instance, we have literally a hub where we're kind of there's 3 providers in a corner, and one does more substance use than we do, and then one does detox. And if you think about this, there's a lot of people that find soothing behaviors and alcohol and substance use that could be involved because of some of these intimate partner relationships. So as an FQHC, we are not allowed to do groups. However, our partners are allowed to do groups and they have peer services. So it works out amazingly well that we're all serving the same clients and we can refer to them to build these networks. And so it works out wonderfully. So we've established process and procedure to be able for them to handle these types of referrals, and it works out beautiful. A lot of times you can do formal agreements with MOUs or BAAs, but really with ROIs, I don't know if you need all that, but you can do that. And another thing that's great is you can do case reviews for that continuity of care and coordination. So let me stop there and see if there's any questions that come up with.
Lisa, we don't currently have any questions, and we have just a couple moments left in your section.
Perfect. So let me talk a little bit about some of the creative ones that we had. So we work with our internal groups. We work with a sexual assault response team. We work with Arise, which is shelter. We work with a SMART team, which is actually an ambulance transportation team. We work with advocates, which is more so children. There's not just adults in these situations, they tend to be children. So we try to get as creative as we can. These are kind of the challenges that I see, making sure that our correct coding and confidentiality is recorded accurately, attitudes and stigma around intimate partner violence. We have one county where I literally have seen 4 generations of trauma, and it's amazing. In this county, it just continues. It's really difficult. I think it's just one county that just continues to show it. System resistance to change, we talked about a little bit earlier. Mistrust from past experience. I think that this is probably our biggest one here, is need for bilingual BHCs in order to best serve our population. Impact on children and other households, and alignment with internal protocols on education. Oops. And my last one is the opportunities for growth. How can we do things the best way forward? Embedding universal assessments into our workflows, strengthening relationships with law enforcement, use EHRs to identify gaps in social determinants of health, expanding those community partnerships, implementing evidence-based screenings in the school-based health centers, and provide non-threatening routine handouts for patients, which there are some great ones out there. And lastly, I ask you, what's in your power and control? Thank you very much for your time and attention. And I will go to any questions that you have.
Excellent. Yes. We don't have any questions in there just yet. Folks, please do put your questions that you have for Lisa in the chat box, or come off mute and ask. Oh, I've got one from Holly. Please come off mute.
Sure.
Thanks, Jen. I was trying to type it and I couldn't quite figure out how to ask it. So thanks for letting me come off mute. Lisa, that was great. Thank you so much.
My pleasure.
I'm thinking about, when you described reaching out to the partner organization during the story you shared at the beginning. And I'm curious, it was your first time reaching out to them, you said, but was that an ongoing partnership that Elevated had? And so they knew, even if they hadn't met you yet, they knew who Elevated was and why you were calling, or was that something you'd had to research? Kind of what was how much did they know? And can you talk a little bit more about how that worked and that partnership?
Sure. So I knew that some of our clinicians had worked with them in the past. However, we had not had a director and for the past 2 years. And so there'd been a lot of fluctuation through our team. And so it kind of been hit or miss, but I knew that we had a good, reputation. And I knew that I was hoping, I was praying, let me put it that way. I was praying that this person would be met with open arms. And so I was, in making that call, I knew that our chief medical officer had used them a long period of time ago, and I kind of done some outreach to others in the past to see, hey, have you used this organization? And I had heard really good things. So it's a smaller organization, and it's really the only one there. So I have since utilized them several times, and have built an ongoing relationship with them. But it was one of those where you kind of just pray and hope that good things happen, that people that get into this, the why.
Lisa, I have lost your sound. I don't know if others have as well, but just at the end there.
Sorry about that.
Okay.
I guess you pray and hope that everybody's why is really rooted in there, and that it all works out. And so thankfully it did.
Excellent. Well, Lisa, thank you so much. We don't have any questions left. Holly writes, thank you in the chat. Thank you. I really appreciate it. And thank you so much for sharing your story on how you guys are thinking about this at Elevated. We've all learned a lot over the last 4 months on this topic, and we wanted to make sure that you all had an opportunity to connect with your state-based primary care associations. This is the last in this particular series, but the state PCAs are charged with supporting you all on intimate partner violence and human trafficking, at least through our next work plan year and potentially beyond. And so we really wanted an opportunity to hear from you guys on what's working for you, where you guys are having some sticking points and would love some more support. And so we are going to be breaking out into rooms. Don't jump. You're just going in with your colleagues and your state primary care associations to have a little conversation, because they want to know how best to support you all going forward as you guys are trying to implement some of the practices that we've learned about over the last 4 months. So very shortly, you should be invited into a breakout room. Katie, go ahead and invite folks into their room. We've already divided you up into your state, so you just have to accept the invitation and pop together, and we'll have your conversation, and we'll see you all again shortly.
Hey, Jen, I had a few people that I wasn't sure of which state they were in. So the person labeled as specials was not sure what state you're in. So let me know, and then I can put you in that room. And then same with Tanaya, I just saw that you're from Hawaii, so not sure which group you wanted to be in. And then, yeah, we have an anonymous iPhone user. So
Hi, this is Sarah Buckholtz. I am in Colorado.
okay, thank you.
Yeah, I was like, where is it? Okay, got it. Thanks so much.
Yeah.
So I'm Tanaya. I work out of Hawaii, but I work with the Pacific Islands, so it's very remote, rural. I don't know if there's a group that includes that.
Yeah, I can yeah, I'll put you with the Dakotas. That
Yeah.
works.
Excellent. All right, and Ben and Molly may have just stepped away. Let's see. Welcome back. I could tell since you guys stayed to the very last second that you guys are having such great conversations. So I wanted to give you as most time as possible. Excellent. Okay, I think we've got folks coming. Awesome. Well, I really appreciate you guys coming and doing this. We have like 3 minutes. And so I'm going to let our team leader from each of the rooms just share real quick about, yes, I know some of you guys are going to have to hop off. We do have the evaluation in the chat for you. So again, thank you to Lisa and for everyone for coming. Your opinions are very important to us. So please do fill out that evaluation. We will share it again in our follow-up email. So that'll come to you if you don't have the moment right now. But I would love to just hear one thing from each of our group leaders about what was meaningful or what you guys are trying to focus on in the future. Colorado, Utah, and Wyoming. You guys go first. Holly or Susie?
I can share.
Yeah.
I think one thing that stood out to me is that folks are really using the tools they've heard in these sessions.
Great.
There were some just examples of ways that folks had heard tools and then had an opportunity to use them pretty quickly. And so just highlighting the importance of asking the questions and then knowing kind of what to do when something comes up.
Fantastic. Perfect. Jill, tell us about the Dakotas.
Well, I think a couple of things came up. I mean, there's been a lot of good information shared. And I think one thing that kind of resonated is that, just to think then particularly in rural communities where IPV might be a little bit more culturally accepted. And so that's an additional barrier. And then it was brought up as, I think, as an opportunity for us. We focus on the patients, right, in this work that we do, but then also like, how could we also craft that approach to be like looking in for employees? Because sometimes you don't know that at the time, but like creating that environment. So
yeah. Excellent. Thanks so much. And Tierney for Montana.
Yeah, one of the things that I heard in our room is that this series was really timely because the centers we were talking to were kind of in an assessment and preparation stage for creating their own internal processes and community response. So that's great to hear. And some of the kind of specific needs that I heard were kind of level setting training and making sure that it's reaching all of the staff, not just clinical or behavioral health, and making sure that it's not something that is kind of relegated to one person's role, even if it is a more specific part of that person's job description. So potentially external training is coming.